Do you know why you do that? Why do you think you do that? Because that test is supposed to predict your chances of having cardiovascular disease and a heart attack or a stroke. Okay? Well, those tests have also an attributable risk. So for blood pressure measurement, right, the attributable risk is around 50%. So 50% of the people who have a high blood pressure, that will predict that they will maybe have a heart attack or a stroke. 50%. Cholesterol is like 43%. Okay? People take, well, males get this prostate-specific antigen, PSA. That's in the 30% range. Now, it depends on which paper you quote. So if you quote me, you know, somebody can always quote another paper saying, oh, maybe it was 40% or maybe, but around that level. Okay? What is the attributable risk of looking at your genetics like this? 81%. It's the best test known to man. Literally. Literally. And you know what? We can already do it. There are two companies that are developing this test using this sort of algorithm. The one that's already available right now is one called Macular Risk, and they are one of our sponsors. And another one's being developed, one of our sponsors is developing the other test. Now, you have to get these in your doctor's office or under the guidance of a doctor. But I'm going to tell you, this can give you a risk stratification that can determine what your likelihood of progressing from, for example, dry to wet. Or if you already have wet in one eye, it gives you a risk stratification for if you're going to develop, how likely you're going to develop in the other eye. Wouldn't that be important to most people in this room? Okay. How do you take the test? Well, you take it by sampling the cheek. You don't have to draw any bloods. You don't have to do anything. All you do is you just swab the cheek like 20 times in the mouth. And then they send it off to the laboratory. Now, the laboratory part takes a long time. It's like 3 to 6 weeks sometimes, you know, because it's a very complex test. I used to do it in my lab when I was at Penn. I actually isolate the DNA, and then I would actually then test it and like sequence it and all that kind of stuff. It took me to sequence a sample probably 4 months. Okay, that was back then. Now they have more fancy equipment. The thing is also, it's based on these papers, JAMA, IOVS. These are very solid journals. You can report sort of in a very simplistic way. Just your risk stratification. So, you know, you as the patient don't want to know that you have the ARMS2 mutation or you have the HTRA1 mutation or you don't want to know that. What you want to know is, how is that test going to predict how bad I'm going to be? And then, what I'm going to talk about later is what the heck can I do about it? Right? So this is from the Macular Risk Score. Again, they're one of our sponsors. What they demonstrate is that they stratified you based on that data from JAMA as either high risk or lower risk. Okay? So if you have a score of 3, 4, or 5, you can see that's above the average population, at least age matched. So thank God it's only 20% of the population. That's great, right? But if you have those, then you've got to do something about it. And I'll sort of go over what I would recommend doing something about. Now, the one problem with this test is that the attributable risk of this stratification is only 81%, so there's still 20% that's not found. But there are certain genes that haven't been found yet. So in the future, you'll probably have to, if you're negative, for example, you might have to get other tests, further tests, because there are genes coming out left and right. Dr. Seddon just found 2 new genes. One is TIM3, another one is hepatic lipase. Now, you don't have to worry about that, but I won't test you later on about that. But these are not incorporated into this test yet, but they might be in the future, once more information and studies have been done. Now look at what these categories tell you. What they tell you is, 1, what are your chances of moving to the advanced AMD? So look at this middle line over here. If you're category 5, your chances are 55 to 94% that you're going to have advanced AMD in your eye. In one of your eyes, or if you have one already affected, both your eyes. Right? That's pretty bad. I mean, but so what do we do about that? Well, what you do about it is that you either get seen every 3 months, or we now have developed a home monitor. Something based on an office situation that can monitor you at home. And I would highly suggest that, even if you haven't been affected by wet AMD or advanced AMD. And I'll show you that in just a bit. Here's a case. Remember, Dr. Kim presented what we do for patients who have these drusen, like a lot of drusen, for example. We see them annually, right? That's what we recommend right now. And we tell them to use an Amsler grid, which unfortunately is a technology that was based on 60-year-old technology, and it's not very good. So we have something better. But so what do we do now? Let's say you're a 53-year-old gentleman who has this amount of drusen, and you get a category 5 risk in this particular test. Well, you know what you can do with it? Well, if it was me, I would see the doctor every 3 to 4 months. Why? Because you want to pick it up early. I told you, if you catch it late, even 6 months late, you're jamming your chances of getting good vision. Amsler grid daily, but I'll tell you that the home monitoring is much better. Consider a foresee home monitor, that's what I'm going to talk about. I'd also consider having your siblings examined, as well as your children. Quit smoking, of course. And also, be more aware that your visual symptoms may not be so benign. That if you start noticing a problem, don't just say, well, I'm going to see the doctor in 3 months. I'll just wait. Don't do that. Not a good thing. Now, why is it important to know your genetic risk? Well, high risk equals more visits to the eye doctor or home monitoring. Think colon cancer. I had a lecture to a couple of doctors on this concept, and one of the doctors was initially skeptical, and then he a light bulb, really shone over his head. He goes, you know what, Mike, I'm positive for the colon cancer gene, and he goes, I was surprised. I mean, he's a young guy, but you know what? He gets a colonoscopy every year. What are we advised? A colonoscopy every 10 years, right? Yeah, or 5 or whatever, and depending on your age. But he's a young enough guy that it was every 10 years. See, it did something for him. And I think that knowing his genetics is going to save his life. It will, because his father had it and passed away a little too young for anybody's good. Now, early detection means less blindness. We have successful treatments for wet. Those injections I was telling you about. The pound of cure. And we can also motivate patients to practice prevention and monitor. And I'm going to, there's a new technology that I actually helped develop, actually. I'm an advisor for them, been for probably 5 years, which is supposed to supplant this Amsler grid. Now, why do we supplant the Amsler grid? Mainly because the Amsler grid doesn't pick up something until you've lost vision. That's been studied. So why do you think we get patients coming in so late? Because, my Amsler grid didn't show anything. And then they have this. That's not good, right? Not in this day and age. Now, when my dad was seeing patients, that was okay, because, we wouldn't do anything about it anyways. But now we can. There's a big difference. Big, big difference. We've also shown in studies with these injections that early detection means better vision. Now, this is a graph of the studies for these injection therapies. And what it shows in the bottom half is when you present what your vision is, and then what's your likely chance of, the y-axis is your likely chance of what will happen after 2 years. What you'll notice is that if you present at 2040, your likely chance of having vision of 2032 is the highest likelihood. Now, if you present at 2200, you're 2125. You know, 2125, I tell my patients, that's not very, very bad vision, it's just very bad. So do we do them a service? No. We would have done a better service if we had caught them when they were 2040, because that's good vision, and 2032 is very good vision, right? So how can we do this? How can we detect, you know, macular degeneration at its earliest form? Well, again, I have a lot of license here because I'm not talking to doctors, so I don't have all these rules and regulations like Dr. Dupree was talking about. So I call it this new machine called the 4C Home, the ADT for AMD, right? Why do we get ADT? I have ADT in my home, and it's to monitor my home so that when I'm not there and somebody breaks in, somebody steals my vision, right? I'll catch them, right? Well, this is the same thing that this 4C Home does, okay? It catches the thief before they can actually do some major damage. This is what the doctors see. The machine works in this way. You take it home, and it's like a little video game. So you have to know how to use a computer. And that video game is well, it should be a 5-minute video game, but I do it a couple of times, and I can do it in like 30 seconds. So I'm very competitive, so that's why you know, I do that. But I'm not supposed to. You do it over 5 minutes, okay? It's probably more indicative. And you plug the machine into your phone line, and it sends the result of your test to a centralized reading center, which is, we get this data set, which is the top part. What you do is you have to get used to it, and you know, you'll have a set way of doing it, and we can identify how well you do that test just by your pattern here at the bottom part of this graph, and that's called a personal threshold. Now, if the test starts showing a deviation from your personal threshold, and the deviation is, you know, 2 or 3 times, then they call you. Just like what happens if my alarm gets set off. You know, they call me and say, "Are you okay? Anybody robbing you? Are you about to be killed?" Or, you know, that sort of thing. That's what they do. They also notify your doctor, and they notify you and anybody else you want to notify, and they implore you to go see the doctor. I'll give you an example of a patient. We were doing one of the studies. This patient here was seen, on the study, right? And was seen on November 16, 2008. They got an exam, routine exam, nothing. Good. The graph didn't show anything, okay? Then he was supposed to be seen in a year, right? Instead, he was called on the phone on April 21st, 2009. And it showed that there was a deviation in that test. To his chagrin, he came in because he says, "I'm not having any problems at all. There's nothing wrong with my vision. What the heck are you calling me about? That's a false alarm." It wasn't a false alarm. He was still seeing 20/20. And then on examination with our great tests that we had, the OCT, he picked it up. He got treated 3 times and has not had to be treated again because he caught it really, really early. And he's still seeing 20/20. That machine did a great deal for him. Now, currently, we're still doing a study in patients who have high-risk AMD. So in my center, we can get you into a study so that this is clinical trials are free. Otherwise, there's a cost to it, and you can talk about the cost outside because they're over here. They're one of our sponsors as well. Now, can we decrease the risk of vision loss? And now I'm going to be talking about the basic science, not the evidence-based medicine. Okay? There are several strategies because we know